Everyone, sorry for the technical difficulties, but it looks like people are now able to join. It's our great pleasure, ETTI's great pleasure, to welcome Dr. Surin to talk to us today about the implementation of airborne infection prevention and control at the National Institute for TB and Respiratory Diseases in New Delhi, and to take us through all of the things that they did in their facility that others may be able to learn from. And of course, we can transfer those his lessons from TB into COVID and other infections. So Dr. Surin, over to you, and thank you so much for joining us.
Thank you, Carrie. I'll just share and hope that I'm able to do it right. Okay, do I have the screen there?
Yes, everything looks good.
Looks perfect. Full. Thank you.
Perfect, perfect.
Okay. Well, Carrie started with the morning, and I'll move on into the evening part of it. A very good evening to all. Yes, it's really a good opportunity, and I'd like to thank Paul and his team and the other organizers for giving the opportunity to share what we have on airborne infection and prevention control in the Institute, and also, of course, generally speaking, also, this would be applicable to other institutions also. I will be a bit general, as well as specifically come to situations where the institution has taken a lead and moving on into the infection prevention and control. So looking at the audience, I think I can be a bit fast also, and hopefully we should be able to complete this entire activity of the presentation earlier than what was anticipated. Well, this is our outpatient department. Most of you who have been to our institute would be familiar with this building. Why I'm trying to project this building is that this building is not more than 15 years old. We, in fact, inaugurated it in 2005. And you see, this building was designed by the national experts, the Hospital Services Consultancy Corporation, which is a Ministry of Health organization, which is into infrastructure for hospitals. And they also consulted with us. And you see, the thing which I want to really highlight here is that in spite of the best of brains in the country going into the designing of this structure, still at that point of time, we made a mess out of the whole thing. Probably we did not understand the whole concept of transmission risk. And if you see here, there are big glass panes. These are not windows, they are just glass panes closed. They look very good, but actually they are very poor when we are talking of containment and when we are talking of transmission risk. And here on the ground floor also, there are, you see, large panes. This is our registration counter. And whatever opportunity one would have for ventilation here is really obstructed too by the air conditioners that you see in this building. So you can fully realize what was our level of knowledge about this particular subject on which we are talking today. And I'm sure there's a lot of learning in this whole journey. And we hopefully in the future, whenever we are going to expand or work towards newer buildings, we will look into the architectural component of it also very closely. Well, this is the outline here. I'll not be discussing on biomedical waste management, but will focus mainly on the concepts of, transmission risk, and then move on into the infection control aspects. Now, this is a picture all of us are very familiar with, but what I want everyone to focus on is that it is not the large or the small droplets which are of significance when we are talking of transmission, but it is really the very small size 1 to 5 micron droplet nuclei, which are coughed out or sneezed out, or even while a person is singing or speaking, that they enter into the environment, they are inhaled by someone who is in the vicinity, and subsequently reach the lungs and cause the infection. And the other part is that you see the small nuclei, droplet nuclei, they remain suspended in the air for quite some time. Now, what does that imply? That implies that the infected particle will be there for nearly the whole of the day. It takes about 24 hours for them to fall from the roof to the floor. So even if a patient is not there, the air could be infected if a patient has visited that area earlier. So whatever precautions that we talk of, or the interventions that we speak on, that really implies that it has to be 24 hours. It has to be round the clock. So these precautions don't have to be limited to situations where the patient is there and then we just forget about the trans. So it is to be universal precautions that we talk of. And I think we all know that the risk of transmission will depend upon the source. That's the TB patient in this case, or could be a COVID infected person if we are talking of the virus. And then how many of these particles or droplet nuclei are there in the environment. And then of course the recipient. And you see, this is the busy OPD. Now, this particular slide was taken way back in 2006, but even today's situation is more or less the same. You find crowded OPDs, you find people who are not practicing any cough etiquette, and the patient-related factors are quite obvious from this particular slide. How many of the patients here are sputum positive, we really don't know, and they would be really transmitting. How many of them are on treatment? We don't know. So the consultant's room, corridor outside it, is, I would say, a highly infectious area, and one has to be very cautious and really, even when you have to approach the best consultant in the country. And not only that, you see, our registration counters here are also heavily crowded. And this leads on to the environmental factors which affect the risk of transmission. There is a lot of overcrowding. Individual has to stay in that same environment for a long time before the person can get registered. And obviously that exposes the individual to greater chance of, getting the infection. And to combine with that, in such congested environments, there is no ventilation. And if you see, there is no opportunity for the air to move out from this particular environment, and the ceiling fans only help to disseminate the infection further from one corner of this hall to the other. So the environmental factors in any OPD in the country, like in our OPD, also is a highly infectious zone. So we have two infectious zones I've covered. One is the corridors outside the consultant chamber, and the other is the registration counter. And then, of course, you see the host-related factors. because there will be many individuals who may be having some immunosuppressive illnesses like diabetes. Some of them may be having cancer. Some of them may be on anti-cancer therapy. Long-term steroid therapy would be there for certain individuals. So strictly speaking, these individuals should have a different area for really, their showing to their doctors for their coughing and all. But unfortunately, that is not so. So there is a lot of mixing going around. And in our institute, you see, the ART center was actually first within our OPD block. And it was only a few years back that we were able to shift it out of that block to an area about 100 meters away, a separate building in itself. And I think we really misunderstood the concept of the coordination and linkage between you see HIV and TB. Whenever we were told that, okay, you have to link up together, we always used to think that they should be closer to each other so that the HIV patients could have access to TB services, little realizing that they would get exposed to the TB patients. So these are, as I say, learnings on the way. And this is the OPD for many institutions in the country, including the AIMS OPD. And in this environment, you see, the question is, are we as health professionals safe? I mean, whenever we are talking of that. And I think the article by Dick Menzies and Joshi and their team is quite clear in that, yes, the risk of infection in healthcare workers is many times more than in the general population. And it is not only the incidence. You see, these are, this is a meta-analysis which is from different countries in the world. And everywhere you will find that the ARTI in healthcare workers is much above the ARTI in the general population. And it's not only the infection, but even the TB disease amongst the healthcare workers is on the higher side. So TB disease incidence amongst healthcare workers in this particular column, and you see TB disease incidence in the country, and you will find a wide gap, and it is true for all countries that that are listed here. So I've just highlighted some areas in red to show that some of these articles have even come from India. So I think it's very well stated that the risk is dependent upon where you are working, even within an institution. And our laboratories are probably at the highest risk. The TB incidence rate ratio is close to about 80 in laboratory settings. And even in inpatient facilities, it is high as compared to, the general wards. So this article is very informative, and I would, I always ask my colleagues to go through this article, because this gives us a lot of insight into where and why we need to go into this whole concept of, you see, infection control, prevention of transmission. So WHO, we are aware that has brought out many guidelines, and recently also they brought out a guideline on this in 2020. Similarly, in India, you see, when we came across this, we looked into the different aspects of infection control, and we tested out different strategies in 3 states in the country, and in different health settings, whether they were primary healthcare, secondary healthcare, tertiary institutions, medical colleges, and so on. And we found that it is possible to implement. You see, in a place like ours, it's always, is it feasible? Yes, in theory, it seems very good, but is it feasible? Can we apply it to our settings? Well, these studies we conducted, and we were able to show that it is possible. And based on that, we had our own, you see, airborne infection control guidelines in the country. And we keep updating these from time to time. So what are, when we talk of the hierarchy of the infection control, you see the administrative control relates mainly to policy and practice. And what is meant by that? You see, as an administrator, I would say it brings about a larger benefit from a very, you know, uh, low cost intervention. Say, for example, in our institution, we realized that, okay, there was a lot of mixing. So what did we do? I mean, as the head of the institution, I just had to put in an office order saying that these wards specifically are reserved for TB patients, and the wards which are on the other corner are for non-TB chest diseases. So just by this office order, I could bring about a lot of reduction in transmission risk. Similarly, you see, relates to MDR TB wards. We decided that we are going to have different ward for MDR TB patients, and we were able to cut the chain of transmission. So by policy and by practicing that policy, we were cutting the chain of transmission, affecting large masses of people. You know, we are having close to around 300,000 patients attending our OPD annually. So you can see the impact that these smaller interventions will have. You know, even in our outpatient department, we said that you see, specialized clinics for other respiratory diseases would be held in the afternoon. So patients suffering from sarcoidosis and other pneumoconiosis and so on were coming in the afternoon. Allergic clinics were held in the afternoon. Again, a simple policy decision, but its implications in terms of preventing transmission were massive. So I would say that in this hierarchy, it is appropriate that administrative controls get the #1 position. And then, of course, we all understand to reduce the concentration of infectious bacteria in the environment is of paramount importance. And there comes engineering controls, there comes the ventilation part of it. And there come other interventions that we talk of for reducing the organisms. It's not only related to, you see, the velocity of air where the people are admitted, but sometimes we are not able to control the ventilation in that manner. And then comes the role of things like UVGI and all that. And lastly, of course, individuals who are working in highly infectious environments, like the laboratory people who have a very high risk, we are always recommending the personal protective measures. The screening of patients' cough corners has now become a norm, but it was not there earlier, you see. And fast tracking of the patients. In our institute, the fast tracking is done by changing the color of the slip. You see, we have a green card for people who are suffering from tuberculosis, and people having this green card have ready access or a faster access to different diagnostic modalities, so that this TB patient remains in the vicinity for a shorter time, and therefore the risk of transmission to others is reduced considerably. And you see, the concept of the cough corner not only protects, you see, people from this transmission, but it has also helped to increase the detection rate. You see, this was a study which was done in Mumbai, wherein it was found that there was a 36% rise in TB case detection from the same OPD, which was earlier not having a cough corner. And the time to treat also, you see, was reduced considerably. So I would suggest that in any busy hospital setting, especially in a general hospital, it becomes all the more important that these cough corners practice should be adopted. These are, of course, health education messages that are there throughout our institute. We have those messages, and we try to space out, you see, as our OPD is concerned. This is the open shaft area in the center of our OPD, and this opens to the top. The second diagram tells this is the sky. The white thing you see is the sky. So the air circulates, comes from the sides and moves up the shaft and then into the atmosphere. So these are, you see, some of the administrative controls. Now this has been a very good learning experience for us. This was a sputum collection center, and I have to thank Paul for teaching us what exactly we were missing. You see, now this has 6 cubicles. It has a central shaft, and the shaft has exhaust fans at the top. And when the exhaust fans are put on, air is sucked from the central shaft, and from these 6 cubicles, it passes through the sieve. And in addition, so this is the ventilation part of these cubicles. But in addition to that, we also had, you see, UV lights fitted in. And we were very happy with this. And this was our brainchild. So at the institute, we always used to feel proud to demonstrate this particular facility. Until one day, you see, Paul came and he demonstrated that the air changes in this cubicle were far less than the air changes outside. You see, he got his venometer out and we did all the calculations. And then when I told him that, well, sir, we also have UV light, just to take care of that situation where adequate, and I was so happy that we've not had to replace the UV light for so many years. And he just smiled and showed me that it was not UV light, it was just violet colored light which was coming out from that tube, because the UV ray reading was 0 in his UV meter. So you see, this was learning. Not that as an idea, as a thought, this was very good, but we forgot the most essential part of any such situation, and that is monitoring. You see, until and unless you monitor what you have done, we realized that the holes in the sieves had got blocked, and therefore the air change was not happening. We forgot to replace the UV lights. We never realized that they needed replacement. We didn't even have the gadgets to measure all these things at that point of time. So we had to then switch back to the age-old dictum of coughing out in the open air. And now we do that. That's the practice that we adopt. And patients collect their sputum in a place which is a bit at a distance from our OPD, but out in the open. It's only covered, the roof is there, but otherwise it is on poles. So that is, again, another bit of learning. And then you see, we always, when we were sitting in our OPDs, this is our consultant chamber in the OPD, and the doctor was sitting where you have the red cross, and the patient was opposite to him. And only later on we realized that whatever the patient is coughing is actually moving towards the doctor because of the flow of air. And then we changed it to what you see in the figure B. A simple changing of the direction itself of the chair and the desk makes the difference. And now whatever the patient coughs goes either out of the window or out of the door, depending upon the movement of air. Institute has an infection control policy, you see, and we have a senior administrator and a clinician who is heading this infection control committee, and they take care of the airborne infection control as well as other infection control. And as I've said, that we have segregated different wards for different types of patients. The nursing section, which is one of our most important sections, and Anita has very well trained her team here, you see, and she rotates the staff nurses between the TB and the non-TB wards. and ensures that you see that her staff nurses are free from the disease through regular screening of the staff on TB. And of course, there has been a lot of trainings. Here you find that the training session going on. And we have these on an ongoing regular basis. It's not a one-time training, but it's a continuous process. And we thank Anita. I hope she's also online. We thank her for the initiative which she has taken in this direction. And in the wards, yes, you see, we had to do a rearrangement of the furniture also, because sometimes we found that, okay, just because of the lack of some space, a window was blocked because of, one of with the almiras was on there. And then we were, very strict on that, and all the windows were kept open. And there were some wire meshes on the window where there was a lot of dust and which was blocked, and that was affecting the air changes in the ward. And we had to then change these wire meshes. So all these things were a process of learning, and as we learned, we tried to implement. Small ventilators which were there above the windows, which are very common in the earlier days. Now, of course, we don't see them, but they also needed frequent cleaning. And wherever you see, we also had built-in exhaust fans were placed just to assist in the circulation of air. PPEs were provided to the staff, N95 masks, and of course to the patients we gave them the cloth mask. And all our patients who are hospitalized are provided with the cloth mask. And even at our registration counters, we provide them with the surgical mask. Anyone who registers at the OPD is provided with a surgical mask. So I think much before COVID came up, the practice of these masks was very prevalent, at least in our institute. And I would say that hopefully that would have cut the chain of transmission in many cases. Then this is part of our bronchoscopy suite, and you see, the bronchoscopy suite, we had some difficulty in ventilation. So here we also installed a UV light. This was a totally air-conditioned room. So because of that, we could not have proper ventilation. But the other rooms where there was suction and where nebulization and all was doing and sputum induction was being done, they were well ventilated areas as such. We have a DRTB ward, specifically designed negative pressure ward is there. And precautions are taken by the, the nursing staff as well as by our administrators to ensure that immunocompromised individuals are not posted in these wards. So these are certain steps that we took. The staff surveillance and rotation on duty were other things that were followed. So these were some of the administrative measures within the institute. Coming to environmental controls, well, we made an effort to ensure that there should be adequate spacing between beds, 6 feet distance between two beds. And this lower ward which you see here, there are cubicles on the side. There is a central corridor and cubicle, and you can see that it is well spaced out area. So this definitely improves the ventilation of that area and brings about a reduction in transmission. Further, you see simple things. A sputum positive patient, place the bed near the window. It may seem, well, it's so logical, it's simple, but yes, till you look at it, it will not happen, right? And to, check on the air changes per hour, we definitely were taught this again with the help of Paul. Paul has been a great help to the institute in terms of the IPC, and he's been coming frequently and guiding us how to go about it. So this is a box, and the person here is holding a flow meter, a digital flow meter, and we, with the help of this, we are able to calculate how much air is circulating from the room which is on the other side of this particular exhaust fan. And this helps us to bring about, you see, the desired level of air changes. Initially, we had, you see, very few exhaust fans. We used to think that in a ward, maybe 3 or 4 are sufficient. But then we realized that in larger wards, we needed more. And the principle, of course, was that the window below which the exhaust fan is, that should be closed. Otherwise, there is just recirculation of air between the window and the exhaust fan. Talking of air changes, what exactly do we mean by that, and how much should be the air change? That is again an important thing to understand. You see, when we are talking of one air change, that means the whole volume of air in that particular room would change once. So one change an hour would mean that the whole volume changes in 1 hour. And if there are 6 air changes, that means 6 times the volume of air in the room should change in 1 hour. Volume of air can be very easily calculated by the length, breadth, and height of the room. And then we can calculate what is the total volume of air which needs to move out of the room. So the general principle is that in high risk settings, 12 air changes an hour should be minimum there. Preferably it should be more than 12, maybe around 15, but definitely not less than 12. And the principle would be that clean air comes in and contaminated air moves out. Now, why this magical figure of 12 air changes per hour? This again comes from the studies done by CDC, and way back in 2005, this was published by them in their weekly reports. And what they showed was that the minutes which were required for a removal efficiency of different airborne contaminants as against the air changes. And they found that if there are 12 changes per hour, then in about 23 minutes, we are able to have 99% removal efficiency. So 99% of the droplet nuclei or tubercle particles will actually be changing, you see. So that is the reason why we have 12. If we have 6 air changes, it's going to take longer. It's going to take double the time, you see. And if we have more air changes, the time reduces. However, we cannot have too many air changes because the fans which are required to do that will produce a lot of noise, and it will be really a very heavy wind effect which will be there. So the compromise is that, well, we have anywhere between 12 to 15 air changes to have a 99% removal efficiency, right? So that is the logic of the 12 air changes. Natural ventilation is the best, but we realized that, as I showed you, even in our OPD, we had blocked the natural ventilation through window panes. So now we've converted those window panes into, the glass panes into windows which are openable. And in fact, we have now aluminum sieves there. It's constantly open. In certain situations, we have removed the glass totally so that you see the air change can take place more effectively. High ceiling, large windows in the wards. This is a old hospital building that we have, has these effects. So maybe in the earlier days, if you find most of the TB sanatorium, they had this particular thing. We never understood it till only recently that this helps in reducing the chain of transmission, So our hospital buildings, also the older wards, they have high ceilings and they have large windows. Well, I think cross ventilation is the best, we all understand, than single-sided ventilation. And side rooms in hospitals, you see, uh, there are many uh, recommendations. Oh, put my patient in the side room. But side rooms really have a lot of stagnant air, and one has to really take precautions, you see, when we are talking of side rooms. And, when we realized this, what we did was that we put in exhaust fans in our side rooms on one of the walls, which opens to the outside, and that helped us to bring about at least some level of ventilation. Now, as far as you see negative pressure rooms are concerned, we are having this model which you see here in figure B, in which you see the negative pressure concept is very simple, that you have a totally closed space and you regulate the air entering into the space and the air leaving out or being exhausted out. So if you exhaust out more air than what you put in, obviously there will be negative pressure inside. So that is a very simple thing. However, the direction of flow becomes very important. So in our rooms that we have, in our MDR TB wards, you see the supply is from the roof and the exhaust is close to the head end of the patient, you see. So the direction of flow is from top downwards and then moving out. You see, essentially, negative pressure rooms are a protection for healthcare workers who enter the room. And whenever they open the door, the air which is dirty inside doesn't come out. You know, it remains inside the room, and the individual doctor or the nurse is at a lesser risk of getting infected. These negative pressure areas are there in our institute, not only in the ward. You see, the same principle we have used for our BSL-3 facility. You know, in the laboratory, we said that there is the highest level of transmission risk. And therefore, the institute has a BSL-3 facility, which has exactly the same principle. It's a closed, 3 cubicles are there, and all of them have you see, separate inflows and outflows, which could be regulated. Ceiling fans have to be put on when the environment is hot. But friends, the ceiling fan should be used only if you have good ventilation, if the doors and windows are open. Otherwise, they will just help in disseminating the droplet nuclei from just one part of the room to the other. So it's very important that whenever you put on the ceiling fan in your wards, please open the doors and windows also. And if that is not possible, you have to close them either during the night time or something, then of course we should have an exhaust fan fitted here and the mechanical ventilation happens. But then when we talk of exhaust fans, how to put them is very important, you know. So one of our very senior consultants, this is not from our institute, it is from Mumbai, Dr. Khapade. So one of your leading practitioners there, I happened to go to his consulting chamber, and this is the way, you see, he had installed the exhaust fan, and he was very happy that well, I am infection free. And then I had to tell him and demonstrate to him that, well, no, this exhaust fan is only circulating the air around the fan, and you are continuing with the same risk as it would otherwise be without the fan. So, you know, we have to learn that, yes, if you have to have an exhaust fan fitted, they should be fitted with a proper, you know, closure on the sides of the fan, so that, you know, definitely the bad air can be thrown out. You know, air conditioning is really not good. So, you know, when we developed our OPD, as I showed you in the first picture, you know, we had a lot of air conditioners because the consultants here all demanded that, no, it becomes too hot in Delhi. We need an air conditioned environment to see our patients. Air conditioners were there. But then later on, we realized that you see, if we close our doors and windows to make a cool environment in the room, we are subjecting ourselves to very, very high risk of drug-resistant TB and even drug-sensitive TB. So now what do we do is that we open the door and window. We also put on the AC so that, the environment is a bit cooler than what it is outside. It may not be chilling, but definitely it is better, and we are at reduced risk. So these are simple things, but it's important to understand, because if we don't understand it, inadvertently we land ourselves into problems. So when we talk of the hierarchy of this, you see, the environmental controls, the proper natural ventilation gets #1 position, because, and therefore you see these days the newer buildings, the architectural designing is very important, and engineers who understand these things, I would say that they are not many. We are fortunate in India to have a few who do a lot of training also. They had come to our institute also, and they then explain how we can have natural ventilation even in TB wards without any difficulty. If we talk of mechanical ventilation, yes, that is only if we can't have proper natural ventilation. The openings in natural ventilation, it should be more than 20% of the floor space. That's a rough idea of calculating whether you are doing it the right way or not, So in case, when one is building a new structure, in that situation, one will ensure that the door and window area is definitely more than 20% of the floor area. Mechanical ventilation, we have already discussed this, but there is, like in the closed negative pressure rooms, we have supply and exhaust ventilation both. We can have with the air conditioning, so no climate control, or with climate control, like that. And sometimes now, you see, when all this ventilatory efforts fail, then we have to resort to something else. We'll have to clean the air, and cleaning the air is by the ultraviolet germicidal irradiation. So I'll have something to say on this UVGI. What exactly is this UVGI? You see, it's a complementary option when it is not possible to achieve adequate ventilation. But proper design, installation, operation, maintenance, monitoring, all these are very crucial. I have already discussed that we burnt our fingers when we made a sputum collection center with a UV lamp which was not functioning, and a false sense of security was there. Amongst the UV, the thing again to understand is that there should be sufficient dosage of the radiation, and 254 nanometer wavelength is the one which is important, you see. UV wave is shorter than visible light. This is just a diagrammatic representation of that. And you will find that UV is of 3 types, A, B, and C. And it is the C UV which is most important, you see. And it has the shortest wavelength amongst the 3. Unfortunately, you see, the sunlight is more of A and B, so it is not that as we thought it to be. You see, in earlier days, we exposed all and everything gets disinfected. Not so until for a sufficient duration there to compensate for the reduced strength. And UV light actually kills the organism, it disrupts the DNA, it prevents multiplication of the organism, and the way you install where the UV light was facing. Are you able to see, sir?
No, your screen stopped sharing.
Now we
Okay,
just see you, you cut off for just a second.
now is the screen visible?
It's good.
Okay, so so this is not the way to install it properly, because the rays get reflected from the roof, and the healthcare provider will definitely be at a risk of the UV. So it's the beam UV which is more efficient, you see. And what it does is that at this particular wavelength, you see 10 to 100 microwatts per square centimeter. At this particular strength, it sterilizes the upper air in the room, you see. And what happens is that by natural airflow, natural convection, the lower air rises up, you see, because of the warmth. The lower air is warmer, it rises up, it gets disinfected, and then it comes down. So by this circulation over a period of time, the entire room gets disinfected. And this is the basic device which is there. It has a reflector, a lamp, and the baffles. And the baffles are very important because they determine the direction of the rays. And this is just telling you that we have to understand how many of these UV lamps are required in a particular area. You see, this, as I said, that the germicidal zone is 10 microwatts per square centimeter wavelength. That has to be there, and only within that, you will be able to kill the bacteria. Going beyond that, the bacteria will not get killed. So it is not simple. It's not just going to the market, buying a UV lamp and putting it up. It has to be done in a very systematic manner, and not only done in a systematic manner, it has also to ensure that you are not overexposing. It also has to ensure that you see this, because the UV lamp loses its strength over a period of time. So you have to ensure that you are giving the adequate dosage of the ultraviolet rays. Otherwise, you see, one could be in problems. There are some side effects, but if it's installed properly, these side effects are taken care of. Eye exposure can lead to corneal inflammation and conjunctival inflammation, but these are then reversible once an individual is not exposed. And skin exposure can lead to sunburn. Some individuals have also stated that even skin cancers can come up if there is direct, but you see, it all depends upon how it is installed. As I've shown you, that it is the beam UV which is the best, so that there is no direct UV touching the individual. It's only cleaning the air above. So these are the UV lights which we have installed in our OPD. This is our OPD. You can see the patients and you can see the UV lights here. And these are the UV lights in one of our wards, which I am also showing. So the attempt here is definitely that you see the infection transmission is minimized. You see, that is the attempt. So both UVGI and HEPA filtration. HEPA filters are actually filters which are put at the exhaust end. They are high efficiency particulate air filters. They filter the air which is moving out, so that the air outside also, we are not throwing in bad air. But you see, these UVGI and HEPA have to be thought of only in the context of high risk settings like MDR TB wards, like you see, we can use it in operation theaters. We have it installed here at the institute. We have one installed in our bronchoscopy suite also. So these are the places wherein there is a high risk involved. But primarily we focus on administrative and ventilatory controls. Well, respirators and masks, I think we are all very familiar with them. Masks are for the patients, and so that the droplets are caught by the mask. You see, the droplet nuclei are not caught by the ordinary surgical or medical mask, because the pores will not filter this particular size. However, the drops and the droplets will get caught. And as you all know that the droplet nuclei will arise from the droplets which are in the air. When they evaporate because of the heat, then they become smaller in size and become droplet nuclei. So wearing an ordinary mask will prevent the generation of droplet nuclei. However, if the medical professional wears this surgical mask in a higher risk setting, that will not be useful, because he can inhale the organism through his surgical mask. So therefore, we need a respirator or N95 mask. And these are, different layers are there in the mask. You've already earlier had a talk on the different masks, so I'll not go into the details on that. But yes, one thing is important, that whenever these masks, they come in different sizes, different shapes, and one need to see the fit test and the seal check before using these masks, so that at least you are appropriately covered in the high risk settings. Well, the question is always there, are these you see, whatever measures that we talk of, are they really helpful? And this study which worked towards, you see, tubercular skin test conversion rate amongst healthcare workers in Thailand proved that, well, the conversion rate from in 95, 97 was 9.3 per 100 person years, and it reduced to 2.2 with these particular interventions. India, on a larger scale, also has embarked on this particular aspect, and currently we are prioritizing at the national level into early detection and treatment of TB and DRTB, as of course that's the best way of reducing transmission. You treat a patient, you make the patient less infected, and prioritize in high-risk settings like the laboratories and microscopy labs, wards, drug-resistant TB wards, HIV care settings, and monitoring is limited to the above facilities only as on date. There are certain indicators for healthcare worker surveillance, screening coverage amongst healthcare workers. What is the treatment coverage of the workers who get TB disease, and what is the TB incidence amongst the healthcare workers? What is the TB mortality? I mean, these are certain things which help us to understand, are we doing well enough? You see, that is the question, because it becomes very easy to be complacent, because you very directly will not get the outcome of this intervention. It is only you see something which you anticipate or expect to happen, that okay, I am cutting the chain of transmission. But if you monitor on a long-term trend, how many of your hospital staff actually got TB? Well, in a longitudinal way, you will find that if you have good practices, the numbers will reduce. So message is very clear that we all healthcare providers are at a risk, and simple administrative and environmental measures are very effective, and they should be uniformly adopted in healthcare facilities. UV lights in certain select situations, and personal protection is only limited settings wherein the healthcare workers are at a much higher risk. Well, thank you, and I hope I have not taken too much time. I've finished within the time frame. Thank you so much for your listening. We can take questions.
Thank you very much, Dr. Sren. It was an excellent talk as usual. And it was great to hear that you were talking about the team there at NITRD, that it involved many people. We have a number of questions, and I ask all the participants and you to excuse me if I mispronounce names. But the first question is from Gyanshakar Mishra, and asks, is natural ventilation variable as wind direction varies with time and diurnal variation? And also, how do you deal with that?
Well, I think it's quite obvious, sir, that natural ventilation will be variable. And you see, we have to work in terms of what is the natural ventilation giving as a maximum effect and as a minimum effect. And the minimum effect should be around not less than 12. That is what is, the hope. And if it falls below that, when in any particular building, then we will have to supplement it with mechanical ventilation. So constantly you'll have to monitor it and see that the minimum doesn't go below 12. So monitoring is the key to it. Opening doors and windows, yes, if you have the open spaces, 20% of the floor area, probability is that you are having good ventilation. But if the wind flow is not to the extent that you imagine it, if everything is static and stagnant and nothing is moving, then obviously the ventilation in that room is not going to be sufficient. We may need to use ceiling fans also in that situation, because if you open the doors and windows and put on the ceiling fans, the air current will move, air will move. So there are different things which one can do to take care of changes in the environmental airflow.
Thank you. And then there was a question that was just sent privately to me, then I'll open it up to the participants. It says, sorry if I missed, how expensive is it to install UV lights? And then I'm going to add something to that question, is how expensive is the maintenance?
Well, Paul, you know it all because you have helped us to install it in our institution. You see, the greatest issue with UV lights is the technique of installation and the monitoring. Now, if we don't pay it, the cost of the equipment per se may not be, you see, a major issue. One can do that one-time spending, but then it has to be constantly monitored. So you need to have a team. So we have a group of 3-4 people who constantly, you see, we started off with on a monthly basis, but now we are having it on a quarterly basis, that we feel that, okay, we monitor how much UV rays are coming out of that lamp that we have there, whether there is reflection happening, whether the louvers are, changed. So that monitoring is very important. And cleaning the lamp is again very important, because if dust and all is there, then the rays which will be there will not be of the level that we want them to be, the strength of the rays. So the total cost of the monitoring, I can tell you, as far as the cost of the equipment is concerned, that varies, and with competition, we learn that cost will come down. We had, I'd like to remember Bill Palmer at this stage. He was the one who installed it at our institute, and it was really at no cost to the institute itself, because we were under a particular project and a program where we got it. But what we learned from him is that it could be provided at a reasonable cost, right? So it all depends upon how many of these you need and where you want to put them, and that can be worked out.
Perfect. And I'm so glad that you said it depends, because that's one of my favorite statements. And Carrie at the end will show it, but on the ETTI website of the Stop TB Partnership, you'll find some documents. There's one document a long document on maintenance but there's a short document that answers this question, I think, very well. It talks about the life cycle costs of UV fixtures, that it talks about the initial cost, the continuing costs, and gives you, what would it cost me over I can't remember, I think a 15-year period to not only buy, but to maintain these fixtures. So I will recommend to folks that they take a look at that document. And then next, Dr. Caparde, if you would unmute your computer, please ask your question.
Very excellent presentation, Dr. Rohit Sari, and really give a lot of insight about this airborne infection control, especially in the health setup. It's not a question, but I just want to say that whatever the airborne infection control measures or guidelines we are used in a tuberculosis, in health setup as well as in non-health setup in Mumbai also, and how they have done the assessment and all, that will definitely help in the COVID-19 pandemic. And that same measures we mostly for the health setup as well as the non-health setup we are used, and that was definitely a supplementary and catalyst for us while using in COVID-19. So there is this is a broad guidelines for airborne infection control that also good for the COVID-19. And another thing that there are a lot of panic situation in the India. We are not touching these highs most of the times and parcels and all these things. There is ultraviolet ray techniques or UV GI techniques are there where we can disinfect this particular files or the old papers or the parcel, so that that security will be there in your mind that okay, we are already eradicated and already disinfected this particular parcels or books or the whatever old documents in the offices, because there are questions come there in Mumbai also that whether we can have some techniques for the disinfecting. So that is just a suggestion as well as the question.
Well, thank you, Dr. Kaparde. You have been instrumental in, you see, the Indian guidelines on infection control. It was during your regime that all this happened. So it's very nice to hear your comments. And yes, COVID situation definitely, I was very happy, when I was informed that the UV light which I have installed in my room in the institute, that will kill the COVID virus also, coronavirus. So, so these things, I think the interventions that we have had in the context of tuberculosis have definitely been very useful, in cutting the transmission risk for COVID.
Perfect. And those guidelines I use in presentations outside of India as well. So it's a very good set of guidelines. And to carry on what I was talking about before is Carrie has posted the link for the Stop TB ETTI working group with the 3 technical sheets that we have, 2 related to respirators, 1 respirators in general, 1 fit testing. And the third one has a section in it with costing for UV. And Sahu also in the chat, and I thank you, Sahu, pasted the links for the UV maintenance manual as well as the document on the right here on the screen about UV fixtures. So on that note, let me, sorry. Oh, Gyan Shankar Mishra, you have another question. If you would unmute and ask your question about the air sterilizers, please.
Hello.
Yes, go ahead, please.
Yeah. So it was a very nice presentation. I just had one doubt. What is the current scientific evidence of air sterilizers in OPD and IPD setting?
No, I mean, are you talking of, you see, the so-called equipments which are placed in a room and are expected to clean the room? Is that what you're talking of?
Yes, sir. Various companies have come about for hospital air sanitizers right now.
Yeah, you see,
Yeah.
I would say that if we had to do for larger settings, it's the UV rays are very useful in addition to what I've said in terms of improved ventilation and so on. Because these so-called air sterilizers which are there, we really don't know their efficiency, and the principles they use are of course the same, but whether their UV is of the proper appropriate strength, whether the air changes that are happening through the equipment to sterilize the air, whether that is appropriate, whether the filter which they say that it's a HEPA filter, but we really don't know, you see. So I would not have too much confidence in using these air sterilizers. I would rather rely on, you see, the more documented things that we have today.
Thank you, sir.
Okay, and then next from Brazil, we have Fernando, who has some questions. And Fernando is on the Union TB Infection Control Working Group. Please, Fernando.
Hello, Dr. Sarin.
Hi,
It was
Fernando.
hi, how are you? It was a nice presentation, very good. I have some observation and doubts that you could clarify me, please. You showed the nurses meeting about training. So I noticed that some are wearing different clothes. So it is about different levels of nurses, or this is a kind of administrative control measures, like or the dark one is going to the high level risk, or the faded one is to low risk. The second question, oh, go ahead.
Okay, so it is more of, you see, administrative responsibilities that they have. That is the color coding. It is not related to the risk of their working environment. So
okay, so about the three hierarchic measures like administrative, engineers, and about the individual, the PPE, which of them do you think is more easy to missing some steps for adherence? In general, by your perspective in your hospital, which ones is necessary put more energy to persuade or to make it clear the healthcare workers to adhere to those measures?
okay, well, I would say the administrative is simpler because that is an administrative instruction and an order, and the director or the head of the institution can enforce it and ensure that everyone follows it. So that is the simpler part of it. The environmental controls which are there, which work towards the ventilation and measuring the air changes, and you see, looking to the monitoring of UVGI and all, that is more difficult, because that monitoring aspect, whenever it comes to that, even though we have teams, we will have monitoring the monitors also. It is something like this. So we have an hierarchy wherein you see the individuals who are really monitoring, they are subsequently also questioned by the next level to ensure that what they are doing is the right thing they are doing, their records are checked and verified, and so on and so forth. Now that is something which could be a bit loose. Regarding the personal protective equipment, well, I will say that in settings where it is made mandatory, people follow that because they feel that this will protect them. You know, that is very clear that when they have to use the N95 mask, in fact, they demand for it. That where is the N95 mask today? I have to wear it. So that again is simple. But the environmental controls, which are very important, crucial, monitoring their effectiveness, their day to day, that is an issue which needs more strengthening.
Yeah, following this line of thinking, I like best the strategy of a small box to monitor the air change per hour. So I don't. I wonder if you faced some barriers to implement this initiative, or if it wasn't the if you do not face the barriers, which barriers could you list for who wants to implement this new strategy? It is a low cost, but can represent um, a great strategy to who is able to monitor. It's not necessary, I mean, a specialist to make this uh, measure daily, or how many times do you use this strategy for monitor, and who is responsible for this study?
You see, for us, the most challenging part was the training part of it, that to make the individuals understand the importance and to train them into how to do it. That was the most challenging part, and that has not only to be done one time, it has to be done repeatedly for the individual to understand and follow it, and then to constitute teams. And these teams also, you see, will rotate between the different groups, so that it's not that, okay, we have assigned just 3-4 people and they constantly do that. No, we have a number of small teams within the institute, that, okay, for this particular period, team A will be doing this, and they will be recording like this, and for this period, team B will be doing. So we split the responsibility and work over our staff, and that helps us. And I would say that the nursing cadre in our institute, fortunately, is very proactive. And because of our nursing superintendent, Anita, she handled it, in a very systematic manner, that the nursing teams could be built up in addition to the other paramedical people, in addition to our, you see, other workers. Someone had to be made responsible, and it was amongst our nursing cadre that we got a lot of support. Doctors will not be that keen to do all these things. That is probably one of the least priority areas. But definitely, as the head of the institution, I felt we got a lot of support from this nursing cadre.
Thank you very much for your answer. I like this pragmatism, to clarify us step and step, and it is our motivation that it's possible. Thank you very much.
Right. Thank you, Fernando.
Okay, and I thank you both for the question and the answer. And next we have Dr. Sujata Baveja from Sion Hospital in Mumbai. Please, Sujata.
Good evening, everybody. Sir, an excellent presentation.
Thank you, Sujata, for being there.
So now, just one question. When we're talking of COVID as a droplet, not as airborne, only in the healthcare setting, how much effective you think UV light is going to be? And especially the upper room. Because there's so many people who are coming to us that, Mumbai has borne the brunt of COVID, and why not we have UV, and we are just, not able to decide what is the right thing to do.
Well, I think
because it's a droplet.
I know, Sujata ji. You see, that is a constant learning. I also find that even globally, this issue, that whether it is only droplet or whether it is primarily droplet and airborne also, things like that are, different studies are emerging and different viewpoints are there, right? But coming straight to your question, that how effective is upper room UVGI for the droplet infection? It's not effective to a larger extent. you need surface UVGI. You see, surface UVGI is also available. It is there. In our institute also we have used surface UVGI, especially in our operation theater we have used it. And we find that it is effective. I mean, we were not able to isolate any organisms once we started. And, we felt that that is a good thing that we did. But the only disadvantage with the surface UVGI is that it has a very high strength of irradiation, and the side effects could be more if any one of us, gets exposed to it. So we have to, in a way, use it and in a closed environment where we are not there, and then open up. It is similar to earlier we used to have fumigation and all that in a closed room, and then so it is little bit like that. But in terms of efficacy, it is very good.
Thank you. Thank you very much, sir. Thank you.
Okay, our time is officially up, but I would just ask people to indulge us for a couple minutes. Dil Patel especially has 3 questions, and we just need to keep them brief, but I especially like the 3rd question. So please, Dilip, if you would unmute, ask your question, then we'll turn this over to Sahu and then Carrie. Thank you.
Hi, Dr. Sarin and Paul. Nice to see you.
Hello, Dilip. Please.
I can hear you.
Yeah, Dr. Sarin, are you able to hear me?
Yeah, you're clear. Thank you.
Okay, it was an excellent presentation, a lot of learning actually. In fact, I remember the days of this Harvard course conducted by Paul and the team. I could revisit most of the things in a practical way during your presentation. So my question is it true that these TB patients are being sidelined or neglected in the days of COVID? Because there's a news report that many TB patients, because in the hype of COVID, the TB patients which need to be addressed, they are not being treated or rather given less priority. Is it true with your institute as well?
Well, you see, Dilip, the issue is it's not only specific to TB. It is, I would say, health priorities. So when we talk of COVID as a priority issue in the country, you will find that the large amount of focus shifts from, other health interventions to COVID interventions, to the extent that even some of the laboratory technicians for the program are now actually engaged in doing COVID testing and all, And there are certain other situations like lockdowns and all, wherein you see mobility of the people are affected, and therefore your case detection has come down as a consequence of this. Then, DOTS, which the traditional directly observed treatment is definitely not happening. It is usually family-based treatment which is there. Recording, reporting, health manpower, that is becoming an issue because the manpower gets deviated to COVID settings. So in that context, I will say that prioritization to COVID has taken away some of the benefits of the program that we have had. But definitely we will have to continue improving upon this particular situation. We should not miss the larger picture in the context of a smaller picture.
Yes, exactly. So my second question, sir, is have you found comorbidity? Means what is the incidence of comorbidity between TB patients and COVID patients? COVID patients having TB or vice versa?
It's not very common that we have had this dual co-infection in a particular individual. That is very, very clear. Why that is so? In fact, some studies are pointing that do we really have a protective effect because of TB and the COVID infection? Do we have a protective effect? So there are some papers on that also. But whatever individuals who do get the dual infection, there you see the morbidity and mortality is higher. So that is definitely there, that the individuals who are having both the diseases, their recovery rates are lower, and they suffer more.
Okay, thank you, sir.
And thank you for the question and excellent answer, excellent presentation. And just so I don't take up any more time, I'm going to turn this back to Sahu, please.
Thank you, Paul. And thank you, Dr. Sareen, for the presentation, and thanks to everyone who participated. Just wanted to say that this has been a weekly initiative. Every Tuesday there is a webinar, but I think now we will give a break for the summer in this part of the world, and we'll come back again. This is a joint effort between Stop TB Partnership and the ETTI working group. And I must say that the COVID pandemic has impacted TB response in many different ways. But one of the things that it has done for this area of work, airborne infection prevention and control, is that everybody is now asking about it and wanting to know more about it. Never in the past, so many people wanted to know about personal protective equipment on this kind of UVGI and other things. So I think this is a great opportunity where TB programs can share experience and expertise, but also it's a great opportunity to get attention and resources to do what we all wanted to do in the past and nobody was paying attention to it. This is a great opportunity. So I would suggest everybody to think like that. From Stop TB Partnership, we are also working with Global Fund and seeing what Global Fund can do to, in this context, to get additional money to fund some of these infection control things, and looks positive at the beginning. So if people have ideas, plans, so I think this is a great opportunity to work further on it. And the last thing from my side is on the website. All webinars are being recorded and placed. So if you want to know more about different webinars that have happened every Tuesday, please visit the Stop TB website or the ETTI website and you will find a recording. Some people have asked why the last 2-week recordings were not placed there. That's because we are still to trace the recording and put it there. It'll all be there, but the last 2 weeks are not there. Other than that, all the previous recordings are there. And also please visit the ETTI website, a lot of resources there. Some were put as links here. So I would like to then, so that's all I wanted to say. Carrie, do you want to say a few words at the end?
Just a few words. Thank you, Sahu. And thank you, Dr. Sareen, for a wonderful presentation. And I think we had some very nice discussion and questions today, which I think is always helpful for everyone. But I also want to thank Stop TB Partnership and Sahu and his team, especially for helping us to organize these webinars over the last month and a half or 2 months or so. And just to reiterate that we will pause for a little while before we start up again with more webinars, but I hope that everyone is able to access the webinars that we have done on the Stop TB website. But again, thank you for everyone for your participation, and I agree with Sahu that now, because of COVID, there's more interest in airborne infection prevention and control, and so I hope that we can keep that momentum going forward. And so we hope to see you all again soon on another webinar. Thank you.
Thank you. Bye.
Bye.
Thank you. Have a great rest of the day.
Bye-bye.